Hey, it's Dr. Bill with just the tip of urology school. Today we're going to tackle renal cell carcinoma. And for those of you who have been paying attention to all of my presentations, let me know if you like my avatar or just plain me. I'm spending a lot of time in the morning trying to make my hair look like the avatar and maybe a waste of time. You guys let me know. In urology, we're going to talk about renal cell carcinoma. In urology, this is a big player. This is a big issue. And like a lot of cancers in urology, more data is pointing to a genetic or hereditary component. So be aware as research changes that there'll be a lot of information thrown at us regarding chromosomal or genetic alterations that may be associated with a particular cancer. That's certainly the case with renal masses or renal cancer. And also look at other syndromes that may be associated with our particular cancer that we're going to be addressing. For renal cell carcinoma, there are currently about four kidney cancers that are associated with syndromes, a heredity component. All of them are autosomal dominant. It is currently recommended that if you identify a patient with a kidney cancer that is under 46 years of age, genetic counseling is certainly in order, and a genetic assessment. And also for any patient who has any other cancers in their family history. We know that because of our increased use of imaging, we're seeing a higher rate of incidental findings. And because of that, a lot of these cancers are absolutely asymptomatic and may fall into a category where active surveillance versus an active treatment would be appropriate. And we want to focus, when we talk about active surveillance, look at those renal masses that are isolated to the kidney and at 2 centimeters or less. There are a number of protocols out there. Our AUA is no exception. There are a lot of clinical guidelines, but basically they revolve on a 3 to 6 month surveillance radiographically, along with a physical exam and laboratory assessment. For renal cell carcinoma, that comprises about 85% of our kidney cancers. It's confined to the cortex, and normally, classically, we see this present in the 6th through 8 decades of life, and more common in men. Risk factors for renal cell carcinoma include smoking and hypertension, obesity, and an underlying theme here, guys, that unlike any other specialty I know in medicine, heart-healthy lifestyles, diet, exercise, and belly fat reduction really serves in our patients' favor. We also know that there's an association with acquired renal cystic disease, occupational exposures, and of course, genetics. The more common subtypes of renal cell carcinoma include clear cell, papillary cell, and chromophobe renal cell carcinomas. A very rare but very aggressive form of renal cell carcinoma is the renal medullary form, more common in Black males with a history of sickle cell trait. It used to be that the classic triad of presentation included flank mass, hematuria, and pain, but actually now that's less than 10% of our patients who are ultimately identified with renal cell carcinoma. I think a lot of that has to do with the increased number of imagings, ultrasound and CT scans that are performed nationally for a variety of other reasons. Despite the fact that we have this increased risk of incidental findings, about a third of patients with renal cancers will identify with evidence of metastatic disease. Be aware of the paraneoplastic syndrome. This used to be referred to as an internal medicine renal cancer, meaning that there are a lot of non-urologic presentations that we see, something called Stouffer's syndrome, which is actually an associated level of hepatitis, not associated with metastatic disease. And once appropriate treatment is offered, the hepatitis resolves rather. This is reversible. There are a number of constitutional symptoms: fever, chills, weight loss, cachexia, anemia, and polycythemia. Note that the risk of malignancy is size dependent. As part of our evaluation, we're going to look at CT scans or MRIs of the abdomen and pelvis, chest imaging, and if indicated, nuclear bone scans to rule out metastatic disease of the bone, and MRIs of the brain if there's evidence of cognitive changes. Because of staging being so important, look at the TNM staging protocol. Over the years, there have been a number of different forms of staging, and this is no different in renal cell. And you're going to find that in other malignancies in the urologic tract. We're going to depend upon TNM staging as well. So be comfortable with it. It's basically assessing tumor size, any evidence of nodal involvement, and any evidence of metastatic disease. Renal cell carcinoma, obviously a brief review rather. There's a lot of information on AUA University, and also look at a number of different apps like UpToDate and your basic journals and textbooks for nurse practitioners and physician assistants. By the way, if you guys are listening, I think my avatar made less grammatical mistakes. Well, I'm keeping it real, and this is in real time. Thanks again for listening. Dr. Bill, just the tip of urology school.